In this module, I'd like to discuss how we make a decision about when to switch therapy. Given that the first-line therapies are not 100% efficacious, many patients will experience some degree of disease activity despite treatment. Now, that disease activity can take several forms. It can be a relapse, it can be a progression of neurological impairment, it can be ongoing fatigue, cognitive symptoms, or changes on the MRI scan. Each clinician utilizes a somewhat different metric with respect to when to consider switching therapy. I think most clinicians would say that the evolution of an asymptomatic brain MRI lesion in patients probably does not bode for a particularly severe outcome and probably would keep patients on that therapy despite a single new small asymptomatic lesion. But what happens when the patient experiences a more severe relapse? And let's say that relapse is associated with accumulation of new neurological disability. Or let's say the patient is developing cognitive impairment or disabling fatigue, in addition to having ongoing disease activity despite treatment. And one, of course, has to first assess whether the patient is really compliant and adherent with their medication regimen. And in the case of the interferons, and in particular the high-frequency, high-dose interferons, make a determination of whether neutralizing antibodies may be present. But in a patient who really has ongoing disease activity, one can consider switching that patient over either to a different platform agent, for example, a switch from interferons to glutathione acetate, or vice versa, or moving on to a second-line therapy. In my personal experience, I tend to take patients who have had a new MS flare or who have ongoing disease activity with accumulation of new lesions on the brain MRI or worsening brain volume loss, and tend to move those patients up into second-line treatment, as long as the patient understands the various risks and benefits. Unfortunately, what we don't have are good controlled studies that really help guide this decision. Primarily for the second-line treatments, we have randomized controlled trials versus placebo to think about, and what we don't have are studies where patients are switched from one therapy to another. So this decision is made in part by the clinician, in part by the patient with review of risks and benefits, and ultimately a consensus is established.